Hi, I'm Patty Lushu. I'm a physical therapist and I was asked to discuss hip goniometric measurements with you. Before we start with goniometric measurements, I'd like to do a brief anatomy and show you what the hip joint looks like. As you can see, it's a ball and socket joint. What that allows is 3 degrees of range of motion so that we can move in all 3 planes. We can move in the frontal plane, the sagittal plane, and the horizontal plane. Here is what the goniometer looks like. When you're looking at a goniometer, you have a stable arm, there's a fulcrum, and there's a moving arm. The stable arm never moves while testing. The fulcrum stays at that landmark that you are given, and the moving arm is what gives you the range of motion of the joint. So today I'm going to use a goniometer, and I have a subject here, and what I'm going to show you is the different ranges of motion. So because it's a ball and socket joint, we have 3 degrees of movement. The first one I'm going to do is flexion. So flexion is when we get the leg to move upward towards the chest. With the goniometer, the fulcrum of the goniometer is going to go to the greater trochanter. So you come out here, you feel for that greater trochanter, you apply your fulcrum. The stable arm goes to the center of the torso, and the moving arm moves with the flexion of the leg. The point of reference here is the lateral part of the femur. So I'm going to ask her to go ahead and bring her leg up. The stable arm stays. Hold your leg up here for me. I'm going to then get the moving arm to point to that femur right here. I'm going to get it to go as far as possible. All right, if we think of hip flexion, the most important thing for us to note is that we do not want to go past 90 if we have a total hip replacement. So 90 is our marker. If I were to put this at 90, that's what it would look like. If we are sitting, we are usually at 90, and that's why we tell them not to bend or not to bring the knee up towards our chest. So that's hip flexion. Because we don't want to move our client around too many times, we're going to leave her in the supine position. And here we are going to do the testing for abduction and adduction. Okay, so abduction, we have 45 degrees. That's when you move the leg away from your body. Adduction moves towards the body, and all we have is 30 degrees. I'm going to stand here. It's not the correct testing position. Normally you will be in this position to test, but I don't want to have my back to you. So I'm going to stand here. The landmarks are both ASISs. So what you may want to do is locate them and then ask your client to go ahead and put her fingertips on the ASISs. So one here, one there. Those are going to be your landmarks. So the one closest to you, I'm testing the right leg, is going to be my fulcrum. The stable arm, the landmark for that is the left ASIS. That's going to be my stable arm. My moving arm, my landmark for the end of the moving arm is the middle of the patella. I'm going to then ask her to move that right leg out to the side as far as she can go without turning her foot out. So that foot should face the top. And right there we have that 40 degrees, and we go back in. And we'll do that again. You're going to move your leg out to the side, keeping your foot facing the ceiling. And we keep the moving arm towards that patella and back in. To do adduction, you need to get the left leg out of the way. So I'm going to ask her to just abduct the left leg out of the way. Move that left leg away. And what we're going to do here, the fulcrum stays the same at the right ASIS. The stable arm stays the same at the left ASIS. The moving arm, again, is that middle of the patella. Now I'm going to ask her to keep the foot facing the ceiling, move the right leg over towards the left leg as far as she can. And that's a deduction. It moves towards the midline. I move the goniometer with it, and I can get that range of motion. Can you come back to center, please? And we'll do that again. Move your right leg out, in towards your left leg, and we have that range of motion. Hip extension is a much smaller movement. They say you can get up to 40 degrees. I think more functional, it's around 20-25 degrees. Again, my fulcrum will be that greater trochanter, so you go ahead and find that, putting that fulcrum there. The stable arm points right to the middle of the torso, and the moving arm, again, it's that lateral femur or femoral condyle that you look for. The leg is very heavy in this position, so normally you may want to get some help to lift it up. I'm going to ask her to hold it there, and I'm going to go ahead and point, and you can see it's not a lot of range of motion, okay? And be sure, as you just saw, you go ahead and put down, my stable arm moved a bit, so make sure you keep that stable. Go ahead and lift the leg up as high as you can, and you point towards the femoral condyle. What can happen here is if you bend the knee and you try to do it this way, which is easier for you to do, if you have tight quadriceps, that you're gonna get a lot less range of motion. You can see how much less she can lift up that way versus this way, and that's from tight quadriceps. So we've done flexion, abduction, adduction, and hip extension. Now we need to look at internal or external range of motion. So again, we're looking at the right leg. We use the floor as to be perpendicular to the floor, and we go straight up perpendicular to the floor, right to the middle of the patella. The moving arm is going to follow the length of the leg. So this way and this way, all right? So if you're doing internal rotation, the foot moves away from the body, but the hip is moving towards the body. So this is internal rotation. We get this here, you get about 40 degrees. Again, make sure your stable arm stays perpendicular. That's internal rotation. The hip moves in, the foot moves out. Come back to neutral. External rotation, we move in, and we get this moving arm straight down the center. Things to note with the hip. The most common diagnosis you will come across is the hip replacement. There are two approaches to the hip replacement. There is the anterior approach. With the anterior approach, there's not many hip precautions because they go anteriorly, so they don't disrupt the musculature on the right side. With the posterior hip approach, which is the most common one, they go right through the hip abductors, and so you end up with hip precautions. The three main hip precautions is you cannot flex the hip beyond 90. So if someone is sitting, their hip will be at 90. This would mean they cannot bring the hip up towards the chest as you would if you were going to put on your socks and shoes, nor can you reach down to pick up an item or to put on said socks and shoes. The other precaution is you cannot cross your legs. This also means you cannot twist, because with twisting, the upper body is appearing to be the same way as if the hip were here, because this is staying in the position, but the upper body is twisting, so you still end up with that as if you were crossing your legs. So no crossing of legs, no internal rotation, so no dropping of the knee in and moving the foot out. The most common diagnosis is hip replacement. One other thing to note is if you are working on bend mobility, you want to maintain alignment of the hip on the body, and that is you want to have a straight line going straight through the center of the hip, through the middle of the knee, through the second toe. So if I'm sitting this way, my hip is not aligned well. I need to have my foot aligned where that line that I have drawn goes straight through the hip, through the center of the knee to my second toe. Thank you so much for joining me today, and good luck in the rest of your class.